We understand the concerns of persons all through the Caribbean about the issue of COVID-19 and specifically the issue of testing. And I will start first by reading the media release which we prepared, which outlines precisely what our role is and some specifics of the dissemination of COVID-19 results. CARFA's Medical Microbiology Laboratory, as a regional reference laboratory, tests suspected COVID-19 cases for 18 of its member states. Samples can only be sent to CARFA from the designated National Public Health Laboratory in a country. Once samples are received, CARFA will produce the results within 24 to 48 hours. COVID-19 results are immediately sent to the chief medical officers at the Ministries of Health, who are responsible for the dissemination. CARFA cannot and will not disseminate any country's results directly to patients or individuals. It is an ethical breach and constitutes a violation of the agency's ethical standards to share confidential patient information with unauthorized persons. In light of this, we ask that physicians and members of the public refrain from calling CARFA for test results. Persons should contact their local Ministry of Health to ascertain what is the process for getting COVID-19 test results. That's the end of the media release.
Thank you, Dr. St. John. I am pleased to invite now Dr. Lisa Indar, Assistant Director, Surveillance, Disease Prevention and Control, to provide an update on COVID-19 testing. Dr. Indar.
Thank you very much, Colin. Good morning to the viewers. I would provide an update on our specific laboratory testing procedures for COVID-19 testing. CARFA's Medical Microbiology Laboratory, which I would refer to as the CMML, is the regional reference laboratory, and it currently conducts tests for suspected COVID-19 cases for 18 of our member states. We currently use the WHO recommended testing criteria, which is published on the website of WHO. The method we use is called the polymerase chain reaction, or PCR. This is a molecular method based on the genomic or the genome present in the bug. The PCR method is the only recommended, WHO recommended method for COVID-19 detection. It remains the gold standard for COVID-19. And why is this? Generally speaking, the sensitivity, which is the capacity of a particular test to detect the pathogen or the virus present in a specimen, and the specificity, which is the capacity of the test to determine if this is one virus or another, they are both 100% for PCR. There are other tests, such as serological tests, which are based on antibodies. These are experimental and have shown to have less sensitivity, so it may result in false negative reactions, and specificity, so that may result in false positives. CARFA's acceptance criteria is based on the WHO guidelines. So samples taken from patients must meet the WHO guidelines. That is, you must have fever and respiratory illness together with travel history or been in contact with a case, or you have these symptoms with no other explanation. But the key is you must have fever and respiratory symptoms. Samples that are the other acceptance criteria is that the samples must be taken within the recommended period of 0 to 10 days from the onset of symptoms. That is important in terms of detecting the amount of viral load that is present. The samples must come in completed laboratory forms. They must be taken under the best clinical practices, and they must be shipped according to international standards of biosafety. What is our rejection criteria? These are samples that are taken from patients that do not meet the definition from the case definition, or from asymptomatic cases. The samples that are taken also that are beyond the period for sampling, samples that do not have the appropriate laboratory investigation forms, and that are not sent with the proper packaging. I would like to refer to you to go to the CARFA website, where all of this criteria is well documented. Currently, we do not test any asymptomatic cases. And why is that? It is simply because the WHO case definitions does not include asymptomatic individuals to be considered for testing. It has been proposed that some individuals do not show any symptoms as they are asymptomatic carriers of the virus, but there is not enough current data to prove this statistical relevance. And while we await that from the WHO, we still follow the WHO guidelines of not testing asymptomatic cases. We also currently do not test any samples after 10 days. Why is this? Because the likelihood of obtaining an amplified viral load that we need to test declines with the progression of the disease. So for samples that are taken more than 10 days from the onset of illness, the sensitivity of the assay may be affected, and it may produce false negative results. At this time too, the WHO does not recommend rapid tests based on serology, since this is a public health risk because of their low or their reduced sensitivity and specificity compared to the PCR. Recently, the FDA has approved clearance for the emergency use of some rapid tests based on PCR methods. However, their global availability is limited because of the high demands. Verification studies are also needed to determine their quality indicators when compared to PCR. Finally, let me reassure you that we have enough manpower to conduct our tests. We are currently working on a shift system to deliver timely results, and this has been aptly demonstrated by our turnaround time of less than 24 hours. We have hired more technologists. The CMML has been impacted by global shortages of reagents. However, our current reagent capacity is, we have enough samples to take us, we have enough media to take us through the next 3 weeks, and we are actively looking for more media. I want to assure you that CARFA and our laboratory is committed to providing science-based results using the WHO recommended testing and providing that in a timely results so that you, the public, can feel a greater sense of assurance. Thank you.
Thank you, Dr. Indar. I now open the floor for questions from the media. You may raise your hand by clicking the hand icon at the bottom of your screen, or you may choose to type your question in the chat. When I invite you to ask your question, please unmute your microphone. Please state your name and the media house that you represent. I will also read questions that are written into the chat as may be necessary. As far as possible, questions will be addressed in the order that they are presented via the Zoom platform. I assure you that we will make an earnest effort to field all of your questions within the 45 minutes or so that we have. The floor is now open to you for questions. Mr. Alain, B. Alain.
Thank you. Good morning. This is Barry Allen from the Nation newspaper in Barbados. This question is for Dr. St. John. Dr. St. John, over the past few days, we've had a number of ministers of health in the Caribbean reporting the amount of tests that have been done and the amount of positive cases that have been recorded. What we're not hearing, however, is how many recoveries of patients we've had who were first found to be positive with the virus. Our first case in Barbados would have been March 16th, and we are yet to find out how many persons have actually recovered from the disease. Can you help us with any information on that?
No, we don't have that kind of patient information. Remember, we are just testing. And I just said it, Mr. Ali, when we get our test results, we send them to the ministries. And I just said that I'm not going to divulge any results, even though we may have tested for persons who are, as you say, in that recovery phase. But I will bring it to the attention of ministers, because there's going to be a Council for Human and Social Development meeting of Ministers of Health tomorrow. So I will indicate that the press is looking for the survivors. I'll tell you something. There's a Facebook friend of mine who posts the number of survivors worldwide every day, and I love to see it. So I think that I will take your query and concern on board and perhaps turn it into a positive.
Thank you very much.
Thank you, Dr. St. John, and thank you, Mr. Aline. Akash Samaru, CNC3, please go ahead.
Hi, good morning. Thank you very much for taking the time, doctors. Now, with respect to Trinidad and Tobago, we get a daily update on how many tests are done, but can you give me an idea as to how many samples are rejected on average?
I don't have a rejection number. The rejections are very carefully aligned to the WHO criteria for testing. So at this point, I can only tell you that, and I can't give you a number. Would you like to ask me another question, Akash?
Sure. What is your average daily processing volume now? How many do you run regionally, and how many for Trinidad and Tobago on a daily basis right now?
We are running everything that fits the criteria that comes to us. I can tell you the number of tests that we have done, and I can tell you our turnaround time to date. Just hold on, let me get the figures. We have tested, Lisa help me here, but I'll tell you what we have done. We have been testing at the rate of $250 per test. So from February 10th, when we first started, to March 35th, we have tested $228,250 worth of testing. Perhaps Lisa can help me with the numbers, because I thought I had them, but I don't.
Right.
What I can tell you is that the rate of testing has speeded up in the last 2 weeks or so. So I see here, Trinidad, as of yesterday, 553, and the regional total as of yesterday, 929 tests.
So just to add to that, so Akash, we probably do about 40 to 50 samples depending on what we receive. So once the samples, once the sample is received, we start the process. So it depends on what we receive. We do have a shift system. So it means once that the samples get here, we will start. We have tested over 900 samples, and of course, based on the media release from Trinidad, you would see over 500 coming from Trinidad.
Thank you, Drs. St. John and Dr. Indar. Question from in the chat, a written question from Radhika De Silva. Why are patients not receiving at least a photocopy of their results? is this a violation of their rights? We have heard of swabs getting lost. Can this happen? She has several questions here, so let me allow you, doctors, to take them as one at a time. The first two I will ask, why are patients not receiving at least a photocopy of their results? And is this a violation of their rights?
We are testing for, when we count up all of the citizens, we have the potential to test for 1 million persons. And we are testing on the behalf of the ministries of health. Sorry, more than 1 million. What am I saying? Trinidad is over 1 million on its own. So we are testing on the behalf of the ministries. And that's why the results go to the chief medical officer. So the ministry systems of ensuring that tests get to the right person are put in place. So it's not a violation of their rights, but it is ensuring that their results get into the right hands. Just as we can't tell who is talking to us on the phone, we can't tell where a photocopy will go. So Radhika, would you like me to photocopy your results if you had had a test to a number and we don't know who is on the other end? That could actually spread information that the patient might not want. So I think that Lisa, can you please, Dr. Indar, can you please answer the other questions?
Okay.
I will ask the other question again. We have heard of swabs getting lost. Can this happen? What is the protocol for this?
Okay. So let us start by first saying CARPHA receives the samples from the relevant public health laboratories. Whatever we receive, we go through a process of an acceptance or rejection criteria. We have, so I can say with 100% assurance, we have not misplaced or lost a swab. Every sample that has come for us, we have accounted for, whether we have accepted it or rejected it. It has to come from the public health agency, from the public health laboratory of a country. I cannot comment of if a swab has been lost from a particular country or what has happened before it gets to CARPHA.
Thank you, Dr. Indar. Radhika is asking again, have you certified any and all testing devices donated by the government of China, and is testing done on weekends? There have been claims of patients' test results being mixed up. I think Dr. Indar has already addressed this question in terms of mixing up of patient test results. And what do we have in place to ensure that this cannot happen? I believe that Dr. Indar has already answered that. But Dr. Indar, have you certified, has CARPHA certified any and all testing devices donated by the government of China, and is testing done on weekends?
Okay, so let me answer the easy question. Testing is done on weekends. As I said, because of COVID-19, we have instituted a shift system. So, and that runs around the clock. So it means also on the weekends. In terms of the verification, we have just received these, and the verification process is ongoing, and you, the media, would be the first to know in terms of what those verification results are.
Thank you. I invite Richard Khan. Please tell me which media house you represent, Richard, and you may go ahead with your question.
Hi, good morning, everyone. It's actually Rashad Khan, and I'm from Guardian Media Limited. Dr. Indar, I would like to go back to something you said in your presentation, that you all have been impacted by the reagent shortage, but there is enough essentially to last 3 weeks. Now, that is at current testing rates, is it?
Okay, so Rishad, thank you for that question. So we would have done our modeling, and we would have, in our modeling, we would have assumed that 1% of the Caribbean population may be impacted, and this is based on international modeling. So we would have been preparing ourselves to then have the capacity for 20,000 tests. So those 3 weeks kind of gives us the buffer. So meaning that, we're anticipating it. So the 3 weeks may be more than 3 weeks, but we are also actively looking for media and supplies, which we have the assurance that we are likely to receive. But there is, and you do know that there is that global shortage, and so that has delayed, some of the media and supplies that would have come to us probably before this. But CAFA has taken a very proactive role. Since this started in January, we would have done our pre-orders. It's just the time it's taken to get to us because of this global shortage.
Okay,
So rest assured.
Yeah, okay, I have a follow-up question as well. I'm not sure if you all would be able to answer this for me, but
Richard, can I
Yes?
please ask you, I think you have either two things open or something, but we're hearing a terrible reverb on your vocals.
Okay, how is it? Is it better now?
That's better now, yes.
Okay, sorry about that. Okay, so our Minister of Health, Minister Terence Yal Singh, indicated last week that CAFA was going to verify the Eric Williams Medical Sciences Complex in Trinidad and Tobago to also do its own testing. Would you all be able to give us an update on where that process has reached?
Okay, so thank you for that question, Richard. So that process has not been completed as yet, but it's ongoing.
Okay, and could this shortage in the reagent affect that process for us?
What I can say that the global shortage is impacting on all countries, but I think Trinidad, like CAFA and other countries, have done a lot of pre-ordering. And when we say shortage, it's a matter of also when we are likely to get the results. I'm likely to get the media and supplies.
Sorry, I interpreted his question in another way. If our shortage would impact our verification of the Trinidad testing, and it's not. That process is well in train, more than halfway done. So that's not going to impact the verification. Moderator?
Thank you, Richard. I will move on to two questions that we have in the chat. From Kijan Haynes, if a patient is tested twice, does that count to the overall national tally? So if TT has example, which is Trinidad and Tobago, has example 583 tests, is this the same as saying 583 people were tested? Is it possible to distinguish between people tested via or versus samples tested? So what is the difference between a sample and a test? And if the person is tested twice, does that count to the overall national tally? If Trinidad and Tobago has 583 tests, is this the same, or 583 samples, I think he's referring to, which is what we get in the report. Is this the same as saying 583 people were tested?
So we will provide a result for every sample we have tested. Now, because of ethical reasons, we do not know the names. So that is and this is something how the presentation of that data from Trinidad is how they would present it. But based on the samples that we have accepted and testing, we provide the results as such. So if a country would have sent 10 samples and they have we have accepted those 10 samples, we provide, or rejected, we provide the results for those 10 samples.
Thank you, Dr. Indar. Radhika is asking again, This is written into the chat. Does CARFA intend to verify claims and accredit tests being offered by an ISO certified lab in St. Augustine, which allows citizens who can afford it to do the test? How many test kits does CARFA currently have? And when will there be a rapid expansion in the capacity to test? So first,
I want to take those.
Dr. St. John, does CARFA intend to verify claims and accredit tests being offered by an ISO certified lab in St. Augustine?
No, we are working with the Ministry of Health in each country. The Ministry of Health would indicate what will be their testing range if public and private sector. The Ministry of Health of Trinidad has not indicated that they are having a private sector entity doing their testing. Next question.
Thank you for that. How many test kits does CARFA currently have? And will there be a rapid expansion in the capacity to test?
I don't know how samples link up with kits. Do you know, Lisa?
So each kit would have about 40 to 50 tests on them. As we say, we have a supply. The process, the PCR process is a two-stage process. So you require two sets of kits. One for the first part called extraction, and then the second part called amplification. We have enough kits to take us through 3 weeks of supply based on our modeling for the first step, and enough in the second step to take us a further 8 to 10 weeks. Again, though, we are actively seeking reagents to be able to fill that gap.
Okay, let me handle the last question. Our testing protocols are guided by WHO. And it is at the point where WHO indicates that we should go to the next stage of persons who can be tested, that we will know if there's a rapid expansion or not. And this also is guided by the availability of test kits globally. Moderator?
Richard, I see that your hand is up. If you have a question other than the one that we have already addressed, you may proceed.
Okay, I have one that is kind of linking to what the response I got from Dr. Indar earlier, right? So she indicated that you all are using international models and stuff to inform your decisions and all these different things. But what I'm considering, and feel free to let me know if I'm wrong, right? In Trinidad and Tobago, we have a high number of non-communicable diseases such as hypertension, diabetes, all these other things which are considered to be risk factors for the virus. So with the testing and stuff and these models being used, is that factoring that into it?
Yes. The answer to that, Richard, is yes.
Okay, excellent. And I have another question that's apart from all of that. In Trinidad and Tobago right now specifically, we seem to be having a bit, it's not an issue per se, but a balancing act between getting information about what is going on with patients versus the right to patient confidentiality. You know, so like we have been trying to get some demographics and certain information. Do you have any guidance on how we could balance that line?
Let me take that one. Richard, we are doing testing on behalf of the Ministries of Health. The Ministries of Health know the specifics and the epidemiology of their nationals and the country profile, health profile. So we ensure that the Ministries of Health make their decisions about the way in which they communicate information. There is overall guidance in terms of risk communication, and then there's specific guidance on keeping confidentiality. So we would have given general guidance. We continue to give general guidance about communications to all of our member states. But I will not be pronouncing on what you want me to pronounce, Richard. Moderator.
I have a question.
Thank you very much. Is it Mr. Aline? Is it that you would like to ask a question?
Yes, I would. I do have a question for Dr. St. John. Dr. St. John, would Carrefour by any chance have any demographic breakdown in terms of positive results for the COVID-19 virus? The reason I ask this is over the past few weeks, we've seen a litany of information coming from all over the place about young persons still being infected with the disease. And remember, initially we had heard that the more severe cases would have affected elderly persons. So I was just wondering if you guys have numbers in terms of how many people 65 and over have tested positive, how many people between the ages of 25 and 65 have tested positive, and how many young people have actually tested positive.
So we collect the information that is sent to us. The Pan American Health Organization has given testing capacity to other countries. And so we do not have the full picture. PAHO has the full picture, I'm assuming, because of the framework of the international health regulations. And it's really important that we do a characterization of the profile, not just epidemiology, but also the symptoms and signs and the disease progression. We do this for any outbreak, but especially for COVID-19, because we are aware that there will be second and third waves. And so we need to do a risk profile for those who will be affected by the second and third waves. Because if you think about it, with all of these measures that are trying to protect those persons with chronic diseases, lung conditions, persons who are older, there will be some people who will not be exposed. But if we open our borders or we increase the traffic from countries that still have transmission, there will be then an inject of another set of disease for those persons who have not had it before. So it's going to be important that we do that, not just demographic, but epidemiological profile. There's also the issue of actually testing people to see if they have it or not. And this may be especially in response to your queries about how young people are affected, because globally the expression in young people, children especially, but also young people, is that they do not necessarily show that there has been an infection. So there's also the discussion of when we go to a stage of doing serological testing to see who has had it. When I say we, I mean the world. I'm not making any pronouncements about CARFA at this point because we do not have a WHO approved serological test.
And a follow-up question, Dr. St. John, this second and third waves that you expect, are you seeing any signs of that as yet?
Mr. Aline, we're in the first, we're about to get into the sloping of the curve. We're right now on the flat part and we're about to get into sloping of the curve that gets into exponential. Please don't put a second wave on top of that, Mr. Aline. Moderator.
I was merely asking the question, Dr. St. John, you brought it up, not me.
No, I'm sorry. I attacked you. But I really cannot handle the thought of having a second wave on top of this first wave that we're preparing for.
But it remains a distinct probability, does it not?
No, a second wave on top of the first wave is not a probability. It's not the experience globally. What happens is that there is an epidemic curve, an increase in cases, a peaking, and then a waning. And then you have a cessation. Usually, if there's no case or no death for 14 days, you're not, you're out of the first wave. But having a second wave demands that the measures that you put in place to curtail disease for the first wave have been lifted. And you know that what is happening now is that most of the countries are increasing their measures. They're expanding profiles. Some countries are going on 24-hour lockdown. They're expanding the range of businesses that cannot open. They're expanding certain suppression measures for at-risk groups. So we are not in the second wave yet. So thanks for giving me the opportunity to understand what was behind your question. Now I could explain all of the elements.
Thank you.
Thank you, Dr. St. John. Thank you, Mr. Alain. Akash, your hand is up. Akash Samaru, CNC3.
Hi, thank you. Can you all tell me if CAFA prioritizes testing?
Dr. Indar, you want to take that? There is a...
Akash, no, we do not prioritize testing. All samples received from countries are treated in an equitable manner. Once a sample is received, we go through an acceptance and a rejection criteria. And then that sample, once accepted, is done immediately.
Okay, my follow-up to that. Take me through the process as part of education. Take me through the process inclusive of timeline and time frame, if you can, from when you receive a sample to when the results are disseminated to the relevant ministry.
Okay, so as the executive director said in the beginning, our turnaround time so far, based on once we receive that sample at CAFA's compound, once that sample is received, it has been an average about 17 hours. So far, it has been less than 24 hours for all countries. Once the samples are received and they're accepted, it goes through a process where it's accepted or rejected. That takes maybe about an hour or two, depending if that the workload. It then goes through the first process of extraction, which takes about 2 hours. And then there is the amplification process, which is the second process. At that stage, in that amplification process, the first thing is to determine if it's coronavirus. And then the second is to determine if it's COVID-19. If it is positive to coronavirus, it is only then we would go on to COVID-19 testing or specific testing. This entire process can then therefore take between 6 to 8 hours. If a sample therefore is received before 8 a.m., then we will get that, the country should get that results within the same day. If it is received then after 4 or 5 p.m., because of the processing, they would receive their results early the next morning.
Can I add something to that? In between, sometimes we do not get all of the information. So we also do a verification with the public health laboratory that sent us the samples so that we get the full information that we need to understand what is going on. So we do have a bit of check and balance there. Moderator, we need to cast the net a little wider, because we have other people, and B, because we are about to close. The Prime Minister of Trinidad and Tobago is having a press conference. And I also have a meeting at 10.
Thank you very much, Dr. St. John. We have about 4 more questions in the lineup, and once we have taken those questions, we will close. So we go quickly to Kijan Haynes. Kijan has asked, does a patient have to be tested again and specifically test negative before being discharged? Dr. Indar?
Right, so generally in the process, you test the patient at the beginning if you are isolating the patient, and you test them afterwards to verify.
Thank you, Dr. Indar. From Sean Embrak, Guyana News Talk Radio. Dr. St. John, would your agency, CARFA, recommend the use of interferon being produced by Cuba and used in other parts of the world? And your thoughts on the use of chloroquine?
Chloroquine and hydroxychloroquine. Okay, so there are a range of drugs that are being tested in clinical trials, different combinations, different prescriptions. There is actually a WHO Solidarity clinical trial that has either commenced or is about to commence. It's a global trial. And what we have been discussing, we have an expert advisory group drawn from several of the member states, experts in their field, lung specialists, pediatricians, infection prevention and control, psychiatrists, psychologists, virologists, and also microbiologists. And what we have been discussing is the possibility of joining with the academic fraternity and also the ethical committees of the countries. We have been discussing the possibility of a Caribbean-wide approach to this clinical trials, because nothing has been agreed to as yet. And the more persons that can be part of a very carefully put together, very carefully monitored clinical trial, the better it will be for the Caribbean. So we are looking at that. We have a proposal. We've been working with University of the West Indies in terms of pulling together a steering group, and we are going to be presenting that to the Ministers of Health as well.
Thank you, Dr. St. John. We're moving right along to A. Curtin. To date, what is the recovery rate for those who would have tested positive? And is it possible to be reinfected after recovery? Ms. or Mr. Curtin, can you please just type in the chat which media house you represent?
So the recovery rate is something that has to be discussed with the member states because we don't have all of the information for all of the patients. And what the thing about reinfection, we have no clear clinical proof or of reinfection. We know that we've seen anecdotal reports and queries, but because this is a novel virus and because this is so early in the outbreak, it's only been going for 3 months after all, there are some questions that we cannot answer at this stage unless we have certain criteria fulfilled. So I cannot say yes or no at this stage on reinfection.
I'm going to take the last 2 questions, and I won't be entertaining any others during this session due to our time constraints. So this is from A. Phillips. Most countries are doing curfews or are in lockdown. However, given that there is no vaccine and lifting these restrictions, would that risk a resurgence? What are your thoughts on the way forward?
Lisa, they're asking us what we're working on now. So the lockdowns and the curfews are all about trying to stop spread, because you know what has been the course of this illness in other countries. COVID is like a thief in the night, steals in quietly, and there is spread, often because most of the cases will be mild or you can't even detect that you had a case. So you may be spreading it without knowing. Each of us has a 50% chance of getting the illness. So the more we restrict the exposure, which is what the curfews and lockdowns are all about, trying to keep things contained, the less likely we are to get illness. But this disease from my perspective has two presentations. One is that very mild presentation. That's 80% of us who get it. But then 20% are going to have hospitalizations. If you have chronic diseases, if you are older, you have greater risk of having to be hospitalized. And if you have more than one chronic disease, you have more risk of being hospitalized and having to go into intensive care. And those who go into intensive care, some will die. So this whole thing about trying to restrict is to try to reduce the numbers of persons who become ill, A, and B, the unfortunate persons who will need hospitalization. And what we've seen in other countries is that these numbers build up really fast all of a sudden. So this is part of the reason why I was talking about the first and the second waves. You go through a period where you have the first wave, your measures allow the containment of disease, but you still have a group of people who have not been exposed. Remember, this is a novel virus. It's not like the H1N1, which circulates every year. So I'm assuming when you say resurgence that you're talking about the second wave, when restrictions are relaxed and other people from outside come in with fresh disease and the cycle of spread starts all over again. And the cycle of persons who were not exposed, getting illness starts again.
Okay. And
Thank you, Dr. St. John.
Colin, can I just add
Absolutely, Dr.
one
Indar.
more
Please
comment?
go ahead.
So travel restrictions for denying entry is just part of the multi-pronged approach that countries are taking to respond to COVID. So to add to what Dr. St. John is saying, the countries are also doing strict measures when it comes to not just testing of the case, but ensuring that they are isolated. So a person who is sick should be isolated. Making sure that persons who would have traveled and are coming back, they are quarantined, meaning that they stay away from other persons, but they can stay at home. And if you are treated, and if you have come in contact with a person, and you do contact tracing, meaning that every person, a confirmed case have been in contact with, you trace that contact and you carry out necessary quarantine. And if they develop symptoms, you do testing and isolation. So that it's that intensive approach together with the travel restrictions so you can break the cycle.
Thank you. And the last question from Radhika again. Can you say whether CARPHA expects to have available for their use rapid tests developed by American manufacturers and recently granted emergency use approval by the FDA?
So as we said before, the WHO does not recommend rapid tests based on serological methods. However, the FDA recently approved the GeneXpert rapid testing. This actually does test for smaller quantities. So some countries are using it because it has been recommended by the FDA. We also have recommended that if countries are using this test, that it should be verified, that we verified their testing results.
Thank you very much, ladies and gentlemen. We have come to the end of this media briefing. I would like to thank you for your participation, and we look forward to your continued support in assisting CARPHA in disseminating important and accurate COVID-19 information to our audiences. Thank you so much for your participation, and do have a good day.
A good day, everyone.
Did I miss something because I had to prepare for my other meeting? Did I miss something?
Dr. St. John, we just ended the meeting and we thanked all for their participation. However, I'm seeing persons still on, so if you would like to make some closing comments, you can.
I would like to try and answer as many questions as possible that are still there. And the other thing that I would like to do is to tell people to send in questions to us so that we can answer questions. So this, I think it was Trevor's iPhone. Trevor, send in the question, but I'll answer the questions that are here now. Moderator, which one did one?
Okay, we do have one more question from Kijan. What does CARFA need from government to ensure that all goes well? What does CARFA need from our member states, our heads of governments to ensure that all goes well?
Okay, I like that question as the question to end off. There has been a coordinated approach to how the Caribbean is dealing with this. CARFA has been leading the health response, but the security cluster, this is cited within the work of the security cluster of CARICOM. So there has been a coordination of disaster and emergency management through SEDEMA. There has been the coordination of the security element and the tracking of persons coming into the region from countries of concern through impacts. And there has also been the support to the testing of samples by RSS, bringing urgent samples since we started testing in February. So the coordinated response is also a multi-sectoral response. And in fact, what the meeting that I'm preparing for in a few minutes is CARFA reaching out to another sector. And we've been doing that kind of work with tourism. What we would like is for the governments to keep working together, to keep supporting the multi-sectoral response so every sector in the Caribbean knows what they have to do. Now we are in the importation and transmission phases of this first wave. And I would like that we again plan for that thing that was asked before. How are we going to get out of this? And how are we going to keep protecting our citizens and also ensuring that we are ready to pick up the pieces of our economy? It is not just the Caribbean's economy that has been hit. It's the global economy that has been hit. So this really needs all of the CARICOM governments to stay together and plan for this and come out of this together with people who are alive and can function, because some of the aftermath of having COVID-19 disease, the worst type of disease, even if you survive, there is all kind of systemic damage, including lung scarring. So we also need to be looking at how we are guarding the different key people in sectors. We need our security people. We need our persons in tourism. We need our frontline persons are key. We need our business persons as well, the ways in which they can protect their staff during this period. CARFA has been putting on series of increasing protective measures for the staff, because for me, my staff are precious. I cannot replace that brain power, that understanding of the Caribbean perspective, and that training. So we are finding ways to protect while we still serve our member states. So these are the kinds of things that we want to keep happening. They've been happening very quietly behind the scenes since January, mainly through health, but now we've really expanded it as much as we've always wanted to the other sectors. So we need to keep working like that together. And we also need to have a global understanding of one way of coming out of this, because we've realized that with COVID-19, the interconnectedness of the world is the reason why we have either had disease or not. The ways in which we have responded to protecting our citizens from getting illness are very interesting to study. The other thing that I would like the governments to do as a bloc is to try to ensure the safety of their citizens during this period of using what is basically a clinical trial of a drug. And then the last thing I would like is for the information on how this outbreak is affecting our citizens to be carefully submitted and compiled. That whole issue of chronic diseases. This is one of the worst hit regions in terms of the prevalence of chronic disease and its complications. So we need to document what is happening to our citizens. We have things we are doing that others may be able to learn from. So we need to document and collaborate. And I want one last thing, because it's a press briefing. Members of the press, I want you to continue to support the dissemination of facts, to suppress the dissemination of rumors, and not to get into scaremongering and downright fake news dissemination. Moderator.
Thank you very much, Dr. St. John, and thank you again to all of you for your participation. If for some reason you have another question or you have a request or some concern or query, please send them via email to comms, which is COMMS-team, TEAM, @carfa.org, and we will be happy to assist you. Thank you again. Have a great day.